face. Oh, yeah, welcome.
Hello.
Richard, can you
Yeah, I can see you. Can you hear me okay?
Yes.
Oh, perfect.
And
Perfect.
with audio before. Welcome to the session on women's health, and I will lead. I will Antun, and I three.
Perfect. And will we get questions just on the chat display there, or our patient?
Computers.
Where is it here?
Hello.
I am Antun, hematologist, adult hematology, and with Burwick, and Dr. Give you an TMA, answer some questions. So we will start with we will talk approximately, we will touch on maintenance for women, for in general with women and then we will TMA, how we immune-mediated TT, how we manage, and then about atypical H2X syndrome and pregnant. So we'll care maintenance in women, TMA, and I believe in this meeting, microangiopathy is TMA. For cancer, we maintenance women with TMA similar to women without. So the cancer screening per the guideline every 3 years, mammograms after 40 colonoscopy. Now so it start at age of 4 for vaccinations. The vaccinations that needs every year for more than 65 with disease, or they are the pneumococcal vaccine. There is no and TTP relapse. Again, I repeat, and in this count of sin. About pregnancy and TMA, important points is the first thing is everybody about TTP, but we need to differential diagnosis of the onset of the gestation is what are those. I am going to go through, talk about preeclampsia. It is pregnancy develop hypertension proteins in the urine, and mostly 20 weeks of gestation or less than 72. And help hemolysis, elevated and low platelets, all at the same time as pregnant 20 weeks or less than 72 hours. Both of them very important because it will resolve after delivery. TTP mixed syndrome is a little different. It can present in any of the regions, more in the second and third or postpartum. When we talk about hemolytic uremic third trimester, first few 2-3 days, while TTP can have atypical uremic syndrome is rare of the pregnancy. For both delivery, the disorder happens. It's not that the delivery was the hemolytic uremic syndrome. So when we talk about how the women present with the pregnancy, for all the TTP, 12 to 25% pregnant, and precipitating factor P if you have previous. Again, as I mentioned before, TTP, we need to tell diagnosis, what we call uremic syndrome, syndrome, because the three also before immune mediated or most common in the second and third and postpartum. So how the pregnant TTP present patients that they are not familiar. We have cardiac involvement that in pregnancy, during pregnant women, in non-pregnant. The treatment is similar. They have more risk. Eclampsia is. Thank you. So I know that is a little busy slide, but I want to guide. When we see a patient that the clinical P, so we will change and steroids. We test results and mention at delivery at the diagnosis. Only deliver if there is indication or is age that needs delivery. With plasma exchange and steroids, the CR13, and it's going to guide us to see if this is P or congenital. This is if the CR13. Now, during anybody they are pregnant with TTP on Adam's CR13 is going, and the levels is between. So if we are in this zone between 10 and 22, to start thinking in those that I mentioned at the beginning, like Tmas or hemolytic help syndrome or Preeclampsia. In the that we use steroids. So here is information about the three how affect the mother and the prednisone. We know that, but in a small amount, find small amounts in the risk. The risk in during the pregnancy, they can develop. But there is no fetal risk with a short course of steroid exchange. The risk for plasma, one is the catheter, because we need a catheter. It could be bleeding or infection. Some patients can develop asthma. So those are the risks for. When we talk about Rituxan, that Dr. Masias is more in the later, the lack of safety of the use of rituximab, but it is okay in postpartum. If we based on in autoimmune disorders, shows no adverse in pregnancy using rituximab. The last that was capitalizumab, safety evidence in pregnant studies were not including pregnant, but it is okay to use. No, it's okay. When we in childbearing to counseling about the first question is congenital TTP or has. So for congenital TTP have been receiving prophylaxis. So you will continue with refusions from the, and then depend how the labs we see if we need to intervene of these plasma, and then if their delivery is induced, it is 7 weeks. We'll continue with the plasma infusion 6 weeks. Like the congenital TTP, when they're TTP or immune mediated, so we will discuss with what we call preemptive. Preemptive treatment is when it's down without having the hemolysis, opinion. So we going down. This is preemptive. Rituximab, and I'm going to touch a little about now during pregnancy. What we do is frequent the anemia that they are CR13. The levels of the CR13 pregnancy has been fall, then we check. So I think it's between 20 and 25 numbers for then we will vary. And then monitor up to 6 weeks. When if there is 10 to 20 in the grades are low dose steroids. And then when other percent in those patients with plasma exchange and the liver. Next. And then outcomes in ATP. Those patients that they have already become pregnant, it's a substantial risk of fetal loss. So also preeclampsia and health syndrome pregnancies, and very important to monitor and have also a class for these patients during. And now continue with
Hello, I'm a dermatologist at Baptist Health, and I will. So we're gonna that we use in TP and pregnancy. Maybe a lot of questions, and I appreciate Dr. the real expert in we use. It's called azathioprine. It's also used in the information that we have, and most from other diseases such as. And there's really no evidence that associated with congenital malformation till birth, and is used. There's a number of patients who can't be on steroids for patients. Azathioprine may be a lot. That we use is called cyclosporin. It doesn't appear to be a major human dust cross the placenta. It has any, although it may be associated with an impurity. The third medication that I'm going to you've heard the most, and it's experiences that have received rituximab for rheumatoid arthritis, immune mediated. Of this case series resulted in full-term delivery. Percent in infants were born 30 weeks. Sometimes though they received rituximab per trimester and had low blood cell counts of infections. There was one stillbirth. It's important the package except rituximab, the recommendation given during pregnancy. Not only in ITTP, but if you used it successfully. So, management of a patient with TTP, an episode of TTP. There's also the management in a patient that wants to get pregnant of TTP. So, a patient with immune mediated a 50% risk of recurrences. 46 the TTP cases occur 30 weeks or postpartum. Percented between patient and 1% presented less than 20. important if you are attempting to is the first step in Adam's TS13 activity periodically, depending on how long it takes you to go. An average of every 3 months with Adam's TS13 activity is we consider it safe than normal Adam's TS13 activity because we know 13 activity is up. So if you and your Adam's TS13 is 70 or 100% safer than if your Adam's TS9 is say 20, 15, and in which your Adam's TS13 activity is especially less than 10%. Right now, having acute TTP, everything else looks normal. When I say platelet count is normal, your LDL can consider preemptive therapy to sport. Typical HUS in pregnancy in 20,000, it affects the 1 in 2. Sorry, they're telling you choppy. Richard? I'm sorry.
Oh,
It's
the audio, yeah,
probably
it just cuts in and out a little bit as you talk. I can hear most of it, but it does. I don't know if it's a signal or not.
Do you want to try this one?
give me one to have third try another.
Try to YouTube. Okay. Can you hear now? Without echo?
There's an echo now.
Okay, how about now?
What about now?
It's a little bit better there.
Okay, so we were talking about atypical HUS in pregnancy. This condition affects 1 in 25,000. Yes, but with echo. I don't know how to take out the echo, Claire. We're in the hallway if you want to join us. Yeah, it's muted. My computer is muted. Perfect. Okay. So as I was saying, it's a rare condition. It affects 1 in 25,000 pregnancies, particularly in the postpartum period. There is a similar component of the gene variants that we see in non-pregnant patients that the ones that present during pregnancies. The outcomes when we look at pregnant and non-pregnant patients that has a diagnosis of atypical HUS were similar. 60 to 70% developed end-stage renal disease requiring dialysis. Now, the therapy of choice for atypical HUS, as many of you may know, is called eculizumab. We know that it's relatively safe to use in pregnancy. It is not present in breast milk. With the observed levels in umbilical cord are not sufficient to affect the concentration of complement in newborns. And it doesn't appear to increase infections, mainly meningococcal infections in mother and neonates. And this is from extrapolated from the use of eculizumab in another disease called PNH. So that's why we say that it may be safe in pregnancy. Patients that are pregnant and are on eculizumab for a diagnosis, a previous diagnosis of atypical HUS, they have when their first episode, of pregnancy is associated with the typical HUS, they have a high rate of remission, and there's been no cases of maternal death or persistent renal failure. When you have a known history of entering pregnancy, about 67% of cases have recurrence leading to termination or preterm births. So I think the two take points for this part. If you have a history of a typical HUS and you are on eculizumab, you can get pregnant and you can continue eculizumab during pregnancy. The key point here is that you need to discuss this not only with your hematologist, but with your nephrologist, because the biggest risk for your case is going to be on your kidney function entering pregnancy. And if you don't have a history of atypical HOS and you present during pregnancy, we can use this medication to treat you. And this concludes the session, the presentation part of the session. Now let me mute. Dr. Burwick is unmuted, and I'm going to look at the chat to see if there's any questions.
This one.
Okay. So one of the things we were discussing, Richard, before was sort of what are your thoughts on delivery if a patient has a history of TTP or atypical HUS? Can they go into having a vaginal delivery? Do they need to have a C-section necessarily just because of that diagnosis?
They should be able to have a vaginal delivery. We definitely try for that in most cases. The harder that TTP is definitely a tough one because of the severe thrombocytopenia. So that one, it depends on the level of, if you're having an acute flare during the pregnancy, it may depend on the degree and the severity of the thrombocytopenia and if it's responding to plasma exchange. Because that can be, with vaginal delivery, you could deliver with lower platelet counts relatively safely, like 20 to 30,000. With C-section surgery, you do like to be above 50,000 in terms of operative bleeding risk. And then for like a neuraxial anesthesia, epidural spinal anesthesia, usually we want that above 75,000. So one hard part, particularly with TTP, because the platelet count tends to go lower than what you see with atypical HUS, is going to be a higher chance of essentially not being eligible for neuraxial anesthesia and a higher risk of needing general anesthesia for a cesarean delivery.
Yeah. So I have another question for both of you until we receive some other questions from the audience. So one of the questions that come very often is about the use of birth control, especially estrogen, in patients with TTP. And I will give a little background. There is few case studies report, and I'm going to say probably 4 or 5 about patients on estrogen developing TTP, but this is as much as data that we have. So in your practice in a patient with TTP, and I ask also Dr. Masias here, do you recommend your patients to use estrogen-based birth control?
It's a great question. I usually say if someone has a known diagnosis of either of these conditions, they do just at baseline have an elevated thrombotic risk. And then if you add estrogen on top of that, I would lean towards a progestin-based therapy like a Mirena type IUD or copper IUD. I think if you could avoid estrogen, luckily there are good options. I don't think it's a strict, contraindication. I think, when we think of DVT-PE, like pregnancy, we kind of go back and say, did the pregnancy provoke the DVT-PE? And then we kind of blame the estrogen effect. So then we avoid estrogen-based contraception. I think you're right. It's a little bit different here, where with TTP, the pregnancy may be partly provoking One, because there's an increase in von Willebrand factor. We know with that von Willebrand factor increases significantly. So that puts a strain, if you have an ADAMTS13 deficiency. And then with atypical HUS, the strain is complement, because we know that complement activation is increased in pregnancy. So there's other factors in play in pregnancy. When we think about why does pregnancy provoke both TTP and atypical HUS, it seems like there are other explanations aside from estrogen. So if that makes sense, but I would say, given just their baseline increased risk of thrombosis, that it would make sense to choose other options if they had other choices.
Yeah. So I think one of the points is, in my patients, and I'm talking about more experience with my patients, if we know that is not the acute event was not related with any or pregnancy or the use of estrogens, that I will be honest, I don't have patients that was provoked TTP with estrogen. Then if we can monitor the ADAMTS13, it is okay to use birth control. If I am more concerned because it was pregnancy-related TTP, I agree with you, and I will give more progesterone or IUD that is less systemic concentration of estrogen. I don't know, Dr. Masias, what you think?
Yeah, I think that I would be worried. I would be worried if we were in a situation in which a patient may have had a relapse. Sorry for the background noise. If a patient had a relapse or an initial presentation of TTP during pregnancy, I may be more hesitant to recommend oral contraceptive pills that have estrogen. But on the majority of the patients, I think that they do well, and the risk of thrombosis in terms of DVTs and Ps is not increased in patients with a history of TTP. So I think that would be a safe alternative for the majority. And we have a question. How aware are physicians when it comes to linking pregnancy, preeclampsia, and TMAs? Are they rapid in considering differentiating TMAs at all stages of pregnancy, including postpartum? I think this is a good question, and I think that it's very dependable on the location, the institution, the provider that sees you. Certainly, when we talk about thrombotic microangiopathies, the initial clinical presentation, maybe it's very similar. And as Dr. Antun was saying in her presentation, it's going to depend on the timing of the pregnancy and other symptoms that are more associated with one ethnicity rather than the other, one etiology, rather than the other. But ultimately, it's all of these diagnoses are clinical, and that because the treatment is different, it definitely requires a lot of awareness from the physician treating the patient.
Yeah, and I think more the awareness is going to be by the OB or the gynecologist OB at the time of having hypertension and hemolytic anemia, because they will call hematology, but probably Richard, you can comment about that.
Yeah, I would say we have a long way to go. There's a long way to go because the recognition is late. TTP and atypical HUS are both rare disorders, rare TMAs, and so they can be missed, and they're life-threatening. So we talk about there's a lot of attention to decrease in maternal morbidity, mortality. Well, TTP and atypical HUS are life-threatening events, and they both have pretty clear-cut treatment regimens. But if they're not recognized, they may not be treated right away. And both of them, it's really important to diagnose and treat right away, because if you go down the wrong treatment path because you don't know that that's what it is, the patient can suffer greater complications. And in pregnancy, we're talking about 3 to 4 days can make a big difference. So if you delay the diagnosis for even 3 to 4 days, in that window of time, you could have a complication. So it's certain institutions are more knowledgeable, where you have physicians who are, more aware of these diseases. But I think we have a long way to go to sort of increase in awareness, and that's part of kind of what we do today. increase in recognition more quickly.
Yes, absolutely. And on that note, not on that note, but I think one of the topics that a lot of people have questions and we haven't really, I mean, we talked about it during the presentation briefly, is the new drug, not so new anymore, caplacizumab, and their use in pregnancy. And as Dr. Antun was saying, I think that it's, it does process the placenta, and we don't really have a lot of information on or any information in if it would cause any neonatal or fetal bleeding. What are your thoughts on using this drug during pregnancy, Dr. Burwick?
That's a tough one. We need data on it, which is hard. That's a whole dilemma with pregnancy. How do we get pregnancy safety data? And pregnant women, I'm guessing with caplacizumab it was probably an exclusion, right, to the original studies. And even to this day, there's, I think, only one case report with a bad outcome, and maybe just coincidental because TTP is associated with bad outcomes. And then you take TTP that's not responding to plasma exchange and steroids, and so you're going to these more advanced therapeutics. You're dealing with a pretty severe condition, a patient with acute disease that's not responding to treatment. So those are tough, really challenges, because there's a high risk for complications with or without the drug, and then trying to assess fetal neonatal risk. I do worry about the bleed-in risk, both from maternal and fetal, right? When you're, if you have a very good inhibitor that's blocking that interaction between von Willebrand and platelet adherence, if that's crossing the placenta, does the baby essentially have some sort of inherited von Willebrand deficiency? And are they going to be having, like you said, maybe it hasn't been seen, but we haven't really studied it on any significant scale. So those patients, multidisciplinary care, right, shared decision making, telling the patient that there's a lot of unknowns. Gestational age is going to be a big factor. If someone's 20 weeks with severe TTP versus 28 weeks or 32 weeks, there's going to be different decisions, whether you're thinking about trying to manage through the pregnancy, whether termination is an option, and then whether delivery is an option. So all those things, that's where you have to have the team together, I think, with the hematologist and your high-risk pregnancy specialist to try to make the best decision for the patient.
Definitely. I think that the key point here is that we know it crosses the placenta, and the question is, does it cross in sufficient amount to cause adverse reactions in the baby? And the answer is we don't know, and it's maybe potentially also extremely challenging, a good research question. I don't know, Anna, if you want to discuss sort of what are we trying to aim with the use of rituximab in terms of research on rituximab and pregnancy.
Yeah, so the use of rituximab in pregnancy is a little controversial, because if we follow the prescription package of rituximab, is telling us that you cannot conceive after 12 months. If we follow some patients not being pregnant, and we use with the use of rituximab, the effect of rituximab could be 6 to 9 months. And now we are talking giving to the pregnant woman more than 12 months that we don't know if they are going to relapse in the middle. So there is some data, and Dr. Masias showed the safe use of rituximab in the second and third trimester. In my experience, discussing very well with the patient the risk and for the mother and the risk for the baby, I have used rituximab in pregnancy, and it was successful without side effects in the baby or the mom. I have 2 patients that we use rituximab, and I want to clarify that 2 patients we cannot generalize, but I think in the consortium we are trying to see how many of our patients receive rituximab and see if we can get more the outcomes of rituximab in mothers and fetus. And hopefully these results will come soon. And Richard and Dr. Masias also are participating in the study. I don't know if you guys have any comments about the study or.
Yeah, I think that the idea of it is that, you know, in an ideal world, we would be able to use rituximab during pregnancy, and that would give us just another tool to, ultimately, our main goal is to prevent any relapses, because we know that a pregnant woman that has a TTP relapse has a number of possible complications that we would like to avoid. So if we can safely use rituximab, that would give us sort of another tool to prevent a relapse. And this, so far, we only have case reports. So through the USTMA consortium, we can get to a bigger number of patients to answer these research questions and others.
Yeah. Dr. Burwick, I have a question for you. Do you have any experience on eculizumab in patients with pregnant and atypical HUS? I know that you did a very nice review of patients using eculizumab in pregnancy, but I would like to know your experience with that.
Yeah, we have used it. You know, like I said, I think you mentioned typical HUS is less common during the pregnancy, it's common postpartum, but I have had a couple patients that have been during the pregnancy. The nice part about it is monoclonal antibodies. So you're talking about most monoclonal antibodies cross the placenta, because these IgG monoclonal antibodies, they bind to the Fc receptor, they cross into the placenta. The nice part about eculizumab, and the reason it didn't get into breast milk or why very low levels in the placenta, it had the Fc receptor binding site was altered in such a way, it wasn't even meant for pregnancy in particular. It was meant to kind of help it evade the immune system. But that design was very unique because it made it so it didn't cross the placenta very easily. The main mechanism is basically impaired, and that's why you don't detect it in breast milk. So that was that's why it's so unique when you compare to like TNF alpha inhibitor, rituximab. That's a real unique part, and it's tolerated very well. So we have a good amount of pregnancy safety data. Initially weekly infusions, and then every other week. It can take it throughout pregnancy. The one thing I think we didn't mention you have to have meningococcal vaccination. That's important with eculizumab. It's required prior to receiving the drug, and then potentially being on empiric antibiotics. Like if you've been vaccinated more recently, then you may have to have a window of time, for the vaccine series with meningococcal vaccine, because it's 2 to 3 months to complete the whole series. So there are some additional issues. Luckily, meningococcal vaccine, things like penicillin that you might need, luckily those are safe in pregnancy. But then it's just, and then so luckily it's a treatment that you can give throughout all of pregnancy and postpartum, which has been that makes it a nice option, because so few of these newer drugs, we often don't have that data.
Great. Thank you so much, everyone, for attending. If you have any questions, please reach out to Claire, and she can direct your questions to us. It was a very nice talk, and thank you, Richard, for joining from so far away.
Yeah,
and,
thank you, Richard.
Thank you guys, and thank
hope to see
you to the USTMA consortium. This was a wonderful event.
Okay.
Have a good afternoon. Take care.
Thank
Bye.
you.
You too.